Hi. Welcome to Knock Knock Hi. I am Will Flannery, also known as Dr. Glaucomfleckens.
I am Kristin Flannery, also known as Lady Glaucomfleckens.
I think you have a better name. Lady, it
Sounds like regal.
It's royalty, right?
Yeah, well, subpar royalty, but sure.
I don't know. Honestly, if I knew it would turn into something, I probably would have chosen an easier name to say.
Yep. Mm-hmm.
But then it might not be as unique. People actually think my name is Dr. Glaucomfleckens.
I know, which is, embarrassing for me. So thank you for that.
It's fine. You don't have to legally change your name, although if you wanted to, I'd be okay with it.
I don't think I'll be doing that,
okay.
no.
All right. Well, we have a fantastic show today.
We do.
We're going to be talking about cancer and oncology. We're going to talk about a few heavy things, because cancer a lot of times is a little bit heavier.
Sure.
But we're also
doesn't always come with the outcome you hope for, so we'll get into that a little bit.
But we're also going to have some fun too. And I, in prepping and preparing for this episode and our guest today, it really got me thinking about our own experiences with cancer.
Mm-hmm.
So I have a history of cancer twice. And the first time I was diagnosed, what year was it?
2013.
2013, I was in med school. I was in my fourth year of med school. Yeah.
Mm-hmm.
And I woke up one morning and I felt a lump in my testicle. And I was just a fourth year med student, so I didn't know a lot, but I did know that my testicle wasn't supposed to divide.
Sure.
Like they don't do that.
Yeah, it's not like you're having identical twins in there.
Right. Your testicle doesn't, for those of you who may not be aware, your testicle does not try to grow another testicle. That if that ever happens, all right, please seek medical care, which I did. I felt it, although it did take me a few days. You may not know this, but I felt it like days earlier.
No, yeah, you did tell me that.
And I tried to ignore it.
Because maybe it'll just go away.
Because maybe it wasn't real, or maybe it's like I was just trying to convince myself that everything was fine.
Because sometimes bodies can be lumpy.
Bodies can be lumpy, and just not really there. That area you don't want lumpiness really. There's a few areas you don't want lumpiness. Your organs being one of them.
Yeah. Mm-hmm.
And so eventually, though, after several days of feeling my own testicles, which men are prone to do from time to time, I convinced myself, it's like, okay, this is not right.
Right.
And so I went in and
it was like Christmas time, right? Like we were at my parents' house visiting for Christmas when you discovered this. And
that's right.
Then when we got home,
that's
you
what
let
it
me
was.
know. Yeah.
And then I went into employee health and I got an ultrasound. They felt it like, oh, yep, this is a thing. This is something. And so they sent me over to radiology. I got an ultrasound, very quickly diagnosed with cancer.
And it was a little weird because that was the hospital where you were working as a medical student. So it was like this weird.
Yeah. So I basically, could just go on my lunch break to go get, which honestly, I probably should have just taken the day off. That's it's kind of a challenging thing to experience. And
if you ever are in a situation, dear listener, where you may or may not have cancer and you're going to go find out, I feel like just either way, just take that day off. Yeah. Don't try to squeeze that in between.
It's a big emotional thing. And I will say one thing that really impressed me was the radiologist who actually was the one that broke the bad news to me. And told me, and I don't know how much you remember, you probably were.
Well, I remember, but I think we had different experiences.
You wouldn't expect it, basically, for a radiologist to do such a phenomenal job of telling someone they have cancer. And so, but the radiologist, it was great. He came in and he sat down and he just was very, calm and told me, okay, this is what it is. This is not a hard thing to diagnose. It was very obvious, and told me what the next steps were and sent me on my way. I had surgery
That day.
That day.
Yeah.
That day, the urologist came and talked with me and did surgery. That was the first and last time I ever actually saw the urologist. He just
Yeah. I don't remember why we had to do it that day. Was he going on vacation or something? Or like what was so urgent about it?
Well, I appreciated that though, because, when you are told you have cancer, you kind of want it out of your body.
Yeah.
And so we were all for it.
No
It was like,
complaining.
let's just get this done. They took my testicle out. I couldn't use my ab muscles for a while after that. That was, you had to wait on me.
You were like a turtle on its shell. Just
I was turtled.
You were turtled.
And on pain medicine. And because the incision is kind of right in the crease of your leg, kind of right in your inguinal area.
Which I was not expecting. As a non-medical
right. So,
man.
So it was, you thought they just went right through the scrotum?
Yeah. I mean, you're unconscious.
That would be
you don't need them anymore.
Painful. And probably high risk for infection. I think that's why they don't do that.
That's not a great spot, yeah.
And so...
but that's no weirder than, than like making an incision in your lower abdomen and then just like sucking them out?
Well, they kind of just pull it out through the... Yeah, it does make that sound, actually.
I thought so.
That's thank you for that.
You're welcome.
Now that's what I'll think about every time I talk about my cancer is the sucking and popping. We'll have to, next time we have a urologist on, let's ask him about that. What kind of popping sound does it make whenever you pull the testicle out?
I am curious.
The incision?
I would like to know.
Anyway, this is getting off the rails. So that was the first cancer. We'll save the second one for another time. Yeah. But there's a lot there. Anyway, but so I was thinking about this and in preparing for our guest, who is Dr. Don Dizon. This is just an incredible guy, Dr. Don.
It's one of those people that makes you feel like you've done nothing with your life.
Yeah. So listen, so he's a professor of medicine and professor of surgery at Brown University.
You may have heard of it.
Yeah, that's right. Director of the Pelvic Malignancies Program at Lifespan Cancer Institute, Associate Director of Community Outreach and Engagement at Legarita Cancer Center at Brown University, Director of Medical Oncology at Rhode Island Hospital, and Vice Chair of Diversity, Equity, Inclusion, and Engagement at SWOG. SWOG? They call it SWOG?
I don't know.
Cancer Clinical Trials Network. Wow.
You got to take a deep breath.
Very, very accomplished. It was just a pleasure to speak with him. And I'm just real happy with kind of, getting to hear his insight, especially as a cancer patient, as a cancer survivor, and as someone who went through it every step of the way with me.
Yes.
It was really wonderful to hear his perspective. So
yeah, oncologists are generally nice people, I think. Like they just care about people.
Very empathetic.
For the most part, I'd say.
I learned some things, even though I don't deal with a lot of cancer, really no cancer, although you can get cancer in the eye.
Yeah. And then you'd probably just refer them away from you, right?
I do. That's the scary thing. And I'm a comprehensive ophthalmologist, so we have subspecialists for that, which is good. But so let's get to it, huh?
Yeah, and just if talking about cancer, death and dying or cancer is not for you, maybe just skip this one or skip to the end to the games, and I think that'll still be safe listening.
Yeah. All right. Let's do it. Here we go. Dr. Dizon. Well, Don, thank you so much for being here. It's a pleasure to talk with you. I've seen you all on social media, and I know that you are at Brown. Is that right?
Yes,
so you're
that's
over
right. I'm at Brown
in Rhode Island. So, how is it out there?
It fluctuates between 60 degrees and 30 degrees, and you wake up either with frost on the windows, but we still have not had any snow. And I should just say, big fan. Really honored to be here.
Oh, well,
big
you
fan
so much.
Of you both.
Well, thanks.
she takes. I take a lot of the credit but she really does most of the work. So I know that you're kind of a big deal at Brown. You're a professor of medicine. and you are the director of the pelvic malignancies program, right? So
I'm also a professor of surgery.
You're a professor of surgery. Okay, tell me about all the surgery.
What an overachiever.
No, so I'm the one that sits in multidisciplinary meetings telling people they should be operating.
Oh, gotcha. All right. Do you have a good working relationship with the surgeons?
I do. In fact, I think I was trained in medical oncology. I was trained through medicine, but they gave me the appointment in surgery because I help a lot of their residents and their fellows with projects. So really supervise a lot of teaching, do a ton of mentoring around research. And so it was kind of a nice thing.
Were you always kind of set on oncology? Like, when did you make that decision? Like, you wanted to go the internal medicine route?
Well, that's interesting. I actually went into internal medicine by default because I ended medical school not knowing what I wanted to do. I went into
that's like
medical
the
school
catch-all specialty, right? Internal medicine.
You can do a lot of different things from it.
Yeah, it's like the undecided major in college.
Well, there is an undecided thing you could do. It's called a transitional year. Then
I did one of those.
You did that. See?
Yeah.
So
I did one of those.
I should have done that. But I went into medical school thinking I was gonna be a pediatric cardiologist. Then I did third year med school and concluded I could not stand pediatrics. And then I did obstetrics and gynecology, and one of the most incredible surgeries I sat through was an ovarian cancer, cytoreductive surgery or debulking surgery, and it was.
Oh wow!
I still remember the surgeon was as short as I am, and so she was on an elevated platform, and we couldn't see the abdomen internally or into the pelvis because of this huge mass. It was the size of like a basketball. And
I thought you were going to say because you were so short, even with the platform. That's where I thought that was going.
The people in the OR, they're good about putting you on a stool, like a step stool thing, right? Yeah. They have those in the OR.
Yeah, and especially if you're the attending surgeon and you're short, they're going to do everything they can. So that's right. But, she and the fellow were talking, and she just kind of reached in blindly and sort of found the stock of this thing. And the fellow was just saying, I was like, what are you doing? And she was just like looking at him. And he's like, what are you doing? And I'm just standing there, just like, I don't know what she's doing. And then you heard this rip.
Ooh.
And she literally ripped it out of the abdomen. And then they got in there, cautery, and they're trying to prevent the bleeding. And it literally took like half an hour. But at the end of it, it was the most beautiful surgical field I've ever seen. The female pelvis was the most beautiful surgical field. And I was like, I'm going to do this. And then I did my obstetrics rotation. I got kicked out of every single room that a pregnant woman was delivering in.
Oh
no.
So I was like, I can't do 4 years of this. So then I went through things and I was like, at the end I was not sure. So by default I went into medicine.
But it sounds like you had a good time in the operating room there.
I did.
So
Did
you ever even think about going the surgical route, surgical oncology?
Only one other time, and it was when I was already an attending in oncology. I moved up to Providence from Sloan Kettering. The first time I was at Brown, because I've been here twice, but the first time I was at Brown, and I turned to this, the guy who hired me at what's called the program in women's oncology, and he was a very forward-thinking person. He's, offered obstetricians training in breast surgery. Where typically it's a field limited to general surgeons. So I kind of went to him and I was like, you know what? Why don't you train me in gynonc? I know I didn't do any OB, but I could do gynonc. I know the field. I know the anatomy. And he laughed at my face and said, yeah, okay. And walked away. So that was the only other time I thought about doing the surgery.
What I'm noticing is you're very persistent. You don't give up easily.
That's true.
Well, it's just, I still, you talk about those moments in medical school, and it really was one of those things. It solidified the notion that I wanted to do oncology, and it also solidified the notion that I actually wanted to do ovarian cancer, uterine cancer, cervix cancer, and that's what I called sort of the pelvic malignancies. And and that stuck.
I also had a surgical experience in my obstetrics gynecology rotation during an emergency C-section, and it was the most blood I had ever seen in my life.
Mm-hmm.
Yeah.
And so shortly after that, I decided I wanted to do ophthalmology, where we it's been, I think, 5 years since I've had any blood loss in my surgery. So, it's those things do shape us, right? It's
They
but it sounds,
absolutely do.
yeah. All it takes is like one experience or one interaction with somebody in med school that just pushes you in a particular direction. It's really kind of remarkable because you can go in so many different directions,
Yeah, you can. I mean, I remember doing my ophthalmology elective and thinking,
You did an ophthalmology elective.
Wow,
I did.
I'm so glad you brought that up.
I told you, I did. I looked. I thought I was going to do neurosurgery for a bit. Then I thought psychiatry. Then I was like, maybe ophthalmology. But the surgery is so precise, and it's like the field is so small.
It's tiny.
It's like,
yeah.
And he's such a big guy, isn't that weird? Like,
you can teach anybody to do it. Yeah, it's.
How do you get the long fingers around those tiny little?
I think it's more. It's like if you even have the littlest tremor, you could like take someone's eye out. Literally take someone's eye out. So.
You do have a very steady hand. So
I didn't have a steady hand. That's it. I don't have
Gotcha.
that.
Well, you still get to call the shots though, as a medical oncologist. Like you're really you're guiding the team. As someone I've had several medical oncologists in my life with my testicular cancer diagnosis and treatment, and you're my favorite type of doctor. I'll tell you that.
That's nice
because
to hear.
it's and a little later on we'll talk about kind of the interactions sometimes that you have with breaking bad news and things, but it's really you do some just guiding your patients through just this very traumatic, difficult thing in their lives is really remarkable kind of what you can do. So
it's a longitudinal. It's sort of like this primary care thing, but it's just a far more stressful longitudinal relationship.
Yeah. One of our big things that we care about is humanity in healthcare, and I think oncologists really are better at that than most, whether by nature or training and just having to do that all the time. I don't know, but
combination of both.
Yeah, but you have to really be able to tap into people's whole lives, not just their cancer, but understand how this affects the rest of their life as well.
Yeah, I think it's self-selective, actually. There are those, I remember being in residency and declaring that I wanted to do oncology, and folks were like, why would you do that? It's so depressing. Everybody dies, and then they were going off in GI, and I was like, I can't imagine anything more disgusting than having to look at people's mouths and looking at what they're defecating. I was like, I just couldn't do it. So I think it self-selects.
There's the same thing with eyeballs. Some people cannot do eyeballs,
so gross.
and it doesn't bother me. But I'm sure you have some tales for us from the world of oncology.
Yeah, I mean, I think the thing that I try to do using social media is sort of humanize the field, which is what I love about what you both do. Because I think still people come into to see a cancer doc, and it's one of the most scary things in the world. What's fascinating is that everybody looks everybody up now. So it is not atypical for me to walk in and have someone seeing me for their cancer and multiple people in the room. And it turns out one of those persons has found me on Twitter or seen a TikTok. And just the level of comfort that they have because they feel like they know me, it's a totally different spin on that. But, because I realize oncology is a very scary thing, my approach has always been to, just say off the bat, if I think something's true, I'm going to tell you what that is. And most often than not, I can walk into someone's room and it's like, tell me about your cancer. What do you know? And then they tell me, and I was like, okay, here's my bottom line for you today. You're not dying. And I say that to everybody, no matter what their stage is. If I feel like they have time, then I tell you, you're not dying. And, just the level of relief that comes up. And then they're actually ready to listen. So I think that's really, really important. But
yes,
I almost, look at the practice of oncology like being in this crazy, acting world, because you go into each room and you have to be that person for that circumstance, for that situation. And I think that's why so many of us feel burnt out after many, many years of it.
Yeah. Yeah, it definitely, all those, the gravity of the situations that we, find ourselves in. More most people don't have risk of,
life or death
in the ophthalmology department. But still, it does over time. It can really weigh on you. And
it's a lot of emotional labor.
But going back to having patients recognize you, because that's, people ask me that a lot. Like, do your patients recognize? They always seem to think that it wouldn't be a good thing. I think it's a wonderful thing. I think it just fast tracks that patient relationship so much, because they feel like they already know you, like you mentioned, and that the comfort that you have. And I've only had positive reactions from patients who have seen my content on social media. Like, it's always like they love it, they like it.
Yeah.
And so I'm sure you probably have noticed the same thing. They enjoy seeing that side of you.
Yeah, and it's both, current patients as well as former patients. Some people I haven't seen in years who'll comment on a video and was like, "Oh my God, how are you?" They won't divulge their diagnosis, or sometimes they do. But, I have this tendency, and I think it's actually one of the things that kind of defines a physician in what we do. I remember people. I remember names. I remember people that I've treated in the past, and when one of those names actually shows up on social media, it's always cool.
Yeah. Right.
But I think people develop a bond too with their oncologist if it's it is, like you said, a longitudinal relationship. And so then when you're done seeing the oncologist, that relationship just ends. But to be able to there's a little bit of trauma bonding, I think, happening. So it's kind of nice to be able to keep in touch. And I think people really want authenticity these days. And so having them come in and recognize you from TikTok and other places, I think that just helps contribute to that sense of you're a real person. I already know you a little bit, and kind of helps accelerate the doctor-patient relationship.
No, I think you're right. And I think I've never had someone say, I don't want you to be my doctor because of who your social media persona is. I use it very professionally.
Right.
Yeah, it's just like, I don't like how you did that dance interpretation. So
listen, if people are okay with the stuff I do on social media, trust me,
sky's the limit.
You could do anything you want. You're not, trying to pretend you're 1,000 different specialties. So
right. I mean, but I think that's like, those of us who are in this space, we kind of have to decide for ourselves what we're going to do with that persona, and some will go directly into sort of, making fun of themselves, knowing that they're making fun of themselves. Some people will adopt humor. Some people will adopt, my big shtick is, I like fashion and I like medicine. So I'm trying to combine them both in a very unusual way, But
I have noticed that,
you just have to decide that.
You are quite fashionable, and I'm getting a theme with some of the guests that we've had, and is that I am
not
on the low end of the stylish scale. I need to up my game.
For the listeners, he's here in a t-shirt and a hoodie and sweatpants.
That's you can't see my sweatpants, but thank you for informing the audience. Anyway, I'm very impressed by how well you are dressed, and all the videos that I've seen on social media. It's really impressive.
I'm very much into neckwear.
That's good.
Yes, it's a lovely
I've seen
scarf.
some very fancy,
nice,
the way
right?
you tie. Yeah, great. And then some of the ties that you've tied. I don't even know how you do those knots that you do sometimes on your videos. Anyway,
you could have a whole other TikTok channel.
Yeah,
about that.
Exactly. How about a podcast yourself on how to do all these?
See, that's it. It's hard because like podcasts, you don't have the visual, and it's
right.
like, what am I supposed to do? Get dressed during like
great medium.
That'd be hard.
I'm just gonna get dressed.
That's right. Well, tell me, what kind of stories do you have from your life as an oncologist?
Well, I think one of the I actually did a TikTok about it, but most recently I've had a couple of people not do well for their cancers. And I tell someone, at the very beginning as well, it's like, I'll walk you through this whole process, whatever happens, and I promise to be honest with you. And, a couple of folks have come by and, we've had to say, I don't think you have lung. I think we should stop therapy. And then they've been admitted to the hospital, and then they make the request to see me. And as much as I really feel I do give a lot, to my practice, because I take it very seriously, at the end of the day, when you're done seeing 25 patients in an oncology clinic, and your clinic was supposed to end at 3, and you're still there at 6:30 doing notes and administrative and stuff because everything ran long, you just want to get out. And so I've struggled with this notion. It's like, I just want to leave, but someone has requested to see me in the hospital, and just playing with that dilemma, and me just sort of, I could just go. And it's like, but they want me to see them. And feeling like if I didn't see them, I would regret that for the rest of my life. And then having to go up and see them and just really meeting with them for that very last time, it's so profound. And I struggled with what to say, And so, for this particular person, and the thing that I've learned about oncology, closure is one thing that's really important for me. So I'll actually say, thank you for letting me in your life and letting me be your doctor. And I have learned from you, and I'm going to miss you, and then say, I'm sorry. And then, just with that, I feel like we both benefited from it. So, I think that's something that I've been thinking about and have been going through quite a bit with recently.
What is in the moment, what is the patient's reaction when you say that?
One of them is relief, just to see that I actually came, that a request has been actually honored. But when I say that, it's profoundly sad. Because I think, well, there's this whole thing about the sort of the war mentality, in oncology. It's like, oh, you're losing, you've lost, you're giving up, right. And when I say, thank you and goodbye and I'm sorry and all this stuff, it's always, they tend to say the same thing. It's like, we tried, didn't we? We tried.
Right.
And I'm always like, we did. And you did not give up. Right. And you are not giving up, and so I think there is a sense of defeat that people have at the end of their lives, which I try very hard for them not to accept that as what's happened. But instead of saying, you're not defeated, turn that frown upside down, you.
Yeah, right.
It's not that. It's just saying, you tried. And you did everything that I ever asked you to do.
Yeah.
And you are strong. And I'm so glad I met you,
Yeah, what just a great message to give to someone, in that moment.
Yeah, and just like acknowledging and even more than acknowledging, but honoring the difficult parts and the sad parts of life, because that's part of being human as well.
Yeah, I mean, I have to say, though, it's like I always walk out of those situations and I'm not sure if I said the right thing. Even as I'm talking to you about it, it's like, I'm not sure if I said the right thing. But the other thing I think is really interesting, I do something in clinic, too, when I have to talk about news. And, people oftentimes, even if you say you're not dying, it's like, how long do I have? How long? So depending on the scenario, I go, you have months. I say you have years. But if I said to you both, it's like, you have months. What do you hear a number when I say that?
I hear less than a year. I hear like maybe 6 months to a year. That's what I hear.
Yeah.
So
maybe less,
maybe less, but then that starts to get into like weeks for me. So
I think we know Kristin would overanalyze it.
I would.
Well, I remember
I would make you give me an actual number, probably.
Right? Well, I remember once I had to tell this family that their mom had months, just months, and she was very sick. And they all panicked, and they all just started, just crying hysterically. Oh my God, she only has 3 months. Can't believe you're telling me she has 3 months. And I was like, I stopped them. I was like, I actually didn't say 3 months.
Oh, interesting.
I said months. But I think everybody hears a number.
Yeah.
They hear it. Yeah. And it's just fascinating to me what they hear.
I wonder if there's any correlation between what they hear and how long the person actually ends up living. I know there's no way to answer that, but are they picking up on some, subtle cues about their loved one's health, like changes in their behavior or their, how their body looks or whatever? I wonder if there's anything to that or if it's just random.
The randomness I'm really curious about is whether or not there's an average number. You know how they say, you have all these marbles in a jar and you ask 100 people to guess how many marbles. That's going to be the average is really close to what it is.
Obviously, it's a skill to learn how to talk with people. And I think you briefly shared a story with me over email about, you were tasked with in a what kind of a situation? It wasn't a real situation, right? It was like you were practicing how to deliver news about a scan. Go ahead and tell that.
Well, no, it was wild. It was an advisory meeting in San Francisco, and as part of it, they were like, "Hey, would you mind if we took photographs of you?" And I was like, "Sure." What do you want me to send? They're like, "Actually, we were hoping for some kind of action shots." I was like, okay, so I'm an oncologist. I'm not sure what you mean by action shots. I was like, no, there's no actions. They're like, we were thinking, why don't you pretend you're talking on the phone? And we'll just take pictures of you while you do that. I was like, okay, so you want me to order pizza? What do you want me to do? It's like, just pretend you're giving someone bad, some news, like really alarming news. So I'm getting on this phone and I was like, all right, it's fine. I was like, hi, can I speak with so-and-so? I was like, yeah, I hate doing it like this, but I do want to review your scans, if that's okay. And, I was like, so the scan shows your cancer's back, and it doesn't look like we can do surgery. And I just started with this, and I was like, it's like, oh no, it's, please don't cry. We'll talk about it more. I just needed you to I wanted you to be aware before you saw this thing. And this entire time I'm looking at this woman and they're taking pictures of me, but this woman is like so into this and she starts to cry.
Oh no.
And I'm like, there's no one on the phone, right? I'm not actually
this is not real
news.
Wow.
Right? You know that. But it was just
you must be a very convincing actor.
Yeah, that's incredible.
I mean, I can get into the role if you want me to, but it's like I can also say "Twinkle, Twinkle, Little Star" on the phone, so you can just take pictures of me saying that too.
As someone who's, every now and then I will have fake conversations with people while I'm filming a TikTok, and it's
every now and then, every night.
It's not as easy as it looks to have a fake conversation on the phone because there's there are tells, there are ways you can tell oh, this is clearly not a real conversation. So that speaks to your acting prowess right there. That's fantastic. It's you gotta how did it turn out? Did everything go okay?
I don't
did they survive?
Did the person on the phone survive?
The person on the phone was totally fine. Laughed through the whole thing.
Oh, good. Well, how did the photos come out? Good. Did they turn out well?
Okay. I think I maybe saw 2 of them. I don't even know if they even used them, honestly. It was like I did this thing, and then the pandemic hit. So,
gotcha.
Everything.
Are you the poster boy for your oncology department? Are you whenever you go to the website, are there pictures of you in these action poses?
No, they're not. There are not. No. I'm more of a background guy. It was
gotcha.
But it's nice for me to travel places and let everyone know that we exist as a cancer center. It's like you think cancer centers, you're thinking of the big ones. You see USCSF. You're thinking Sloan Kettering, and So it's nice for me to say, hi, I'm from Brown's program, Legorata Cancer Center or Lifespan Cancer Institute. And people are like, Lifespan. what's lifespan? I was like, Brown, Providence.
Yep.
Right.
Yep. I mean, you must be.
Just
Is
do
that
these,
the
like,
only?
word
Is it the only
associations.
Is it the only cancer center in Rhode Island? Pretty much.
No, actually, it's, I was mentioning that I was here before. So my first job out of when I left New York City was at something called the Program in Women's Oncology at Women and Infants Hospital of Rhode Island, which is a really good program specific to breast and gynecological cancers. I left there and went to Mass General for a bit, and then was recruited back to Lifespan Cancer Institute, which is the bigger general medical oncology and hematology program.
And you've been there for now, how many years?
5 years.
Okay.
5 years, yeah.
We're doing fantastic work. Let's take a break. We're going to take a break, sure. And then we're going to come back and we're going to get some hands-on oncology Breaking Bad news training. This is going to be great. All right, so we'll be right back with Dr. Dizon. A big thank you to all of our listeners. This is a new show where just spread the love, share with everyone you know, leave a rating and a review. Be honest. Like, tell us what you think.
Yeah, I want to hear the feedback.
We want to hear that. We want to improve. We want to have a podcast that you all love as much as we love it. And later on, we're going to share some stories, your own medical stories from listeners. You can share yours, knockknockhi@human-content.com. We also have a Patreon. Come hang out with other members of the Knock Knock Hi community.
And us.
And us.
We're over there.
Yeah, we are there. Early episode access, bonus episodes, including a whole new show. Yeah, we're doing the monthly eye exam. We're going to react to
medical
TV shows, movie clips. So check it out. All right, let's get back with Dr. Dizon. Okay, we're back with Don Dizon, and we're gonna something that Dr. Dizon here is better equipped than like the 99% of the population out there is Breaking Bad news. We've talked a little bit about Breaking Bad news already, and so what I thought we could do now is I want you to give us your 3-minute approach to that interaction. So you're telling someone something that they don't want to hear. What is your approach? And then what we're going to do is Kristin and I are going to break some bad news to each other that we have not told each other about. So it's going to be, we have no idea. I have no idea what kind of bad news she's going to give me. She has no idea what kind of bad news I'm going to give her. And then we're going to have Don critique us and give us some tips and tell us how we did. So Don, I'm going to leave it up to you. So go ahead and give us your few-minute approach to how you do this.
So I think that the first thing is always to ensure that you and the person you're talking to are at eye level, and you want to sort of equalize it physically as much as possible. So I'm always like, I'm sitting down if they're sitting down. I'm never standing, although I'm not that tall. I'm never standing if they're seated. If they're lying down, I try to get them to sit up so that, you have that eye level. The second is not to look away from people when you're having to give bad news. Holding eye contact is a very difficult thing for a lot of us, especially when we're the ones uncomfortable. But I think it's really critical because you can really tell what people are based on their eyes. I proverbial window to the soul, but I can tell if someone is absorbing what I'm telling them, if they're freaking out, or if they're about to just fall apart. I can tell. Mm-hmm. And by looking at their eyes, you can also then set your tone and also your delivery. So one of the things that I always, I use, it's something I use quite a bit. I use little breaks. So I'm quiet for a bit. I don't ramble on and go, bad news, but here's the plan, and then this is outcome, and then I'll see you. No. It's sort of like you deliver things and you're watching them. They'll tell you when they're ready. So much of it is the interaction as much as it is about the news. The final thing I would say is I don't speak in platitudes, because I think platitudes can lead people to become more confused than not. Sort of if they're reading their CAT scan and saying consistent with recurrence or suggestive of, of cancer or, all of these other words. If I think it's cancer, I'll tell you. So it's like your cancer's back, and I don't say, things like, a toxic positive comment. It's like, it could be worse. That's not something I'll say.
Yeah.
And I'll say, these are your options currently, rather than, we can do millions of things for this. Really trying to provide specificity as much as possible. And in the worst case scenario, I think someone is looking at their last few months of life, and this is always very difficult. I in oncology especially, I will use the phrase, with or without therapy, you're going to live as long. Because sometimes I need treatment because I want to control these things, which means I'm going to live longer. At some point after 13, 14, 15 trials of therapy, if it's just working, I'll say, you only have months, and with or without therapy, you'll live as long. And that's a very difficult line to deliver to somebody, but it helps them put in perspective how they want to live the rest of their lives. And that's the important thing. It's like, I might think, if it's me, I would want to know if I'm at my 6-month mark, because I'm getting out of here. I'm taking my family. I'm going to the Caribbean. I'm going to die on the beach where I'm going to be happy. But other people are like, I will die in an ICU on a vent with chemo dripping into my body. That's how I want to die. I want to die trying. And who's to say who's wrong?
Right. What's the first thing you say when you go, you get eye level, your position, you're in the right setting? Do you have like something?
What's your icebreaker?
Yeah, right.
It's actually going to sound really corny, but honestly, in that situation, sitting down, getting eye level, looking at them, I actually start with, how are you doing? How are you doing?
Yeah.
And
lets them kind of see where they're at, right?
Yeah. Then they'll say, it's like, I'm okay. I'm terrified of just what you're going to say next. It's like, what did the scan show? They'll tell you where their mind is. No one's going to hear that question. How are you doing? Oh, great. I went to the, market. And, I'm going to make chicken when I get out. That's not that. Because oftentimes it's never a surprise if we have to deliver scans. Yeah.
Yeah. Yeah. Well, I think also when the oncologist walks in through the door and gets eye level with you, and I think you get a sense what's coming, right? It's like, it's not, you're kind of, I imagine patients are bracing themselves a little bit for what's coming next. So
most of the time they are.
All right.
They are bracing. Yeah.
Yeah. I guess maybe sometimes it's a surprise, and that's probably even harder.
Well, I mean, I think it's human nature to be hopeful, to say it's not going to be bad, or it's not going to be that bad, or, I'm not going to hear this and that today. I think we want to have hope. And so my job is, no matter what the news, is that they leave the office with hope. And that's my objective.
Yeah, that's super important.
Well, okay.
So we got to let's do a quick recap here.
Okay.
You get eye level.
Okay.
You maintain eye contact.
Yep.
You
break the ice.
Just tell it like it is.
Yeah. Avoid platitudes.
Yes, first break the ice. Ask them how they're doing.
Yeah.
Avoid the platitudes. What are we missing?
And just be empathetic.
Yeah.
You be empathetic with me when you're giving me some bad news.
Yeah, that's going to be hard for you.
All right. I have plenty of empathy to give. All right. So, all right. You're gonna.
Do you think we're ready, Dr. Dizon?
I think you're both ready.
Okay.
Let's do it. All right. All right.
Okay.
You're going to go first here. Okay.
I'm going first.
Yep.
I'm going to deliver some.
You're going to deliver some bad news to me.
I have see, but what if you have to go up to get onto eye level?
You know what? I'll go down. There's like a foot
difference
between us.
So we're as eye level as I can
pretty
be.
Good.
I mean, literally, I'm a very short person.
That's good. All right, we're good.
Okay, good. Me too.
All right.
Okay. How are you today? Is touch allowed? Can you touch them? What if you're married to them? Is it okay then? Can you assume consent?
Like a little touch on the shoulder or the...
Yes, the shoulder.
Yeah.
Somewhere
that's good.
Above board. Okay. How are you doing today?
I'm doing fine. Thank you. A little stressed.
Okay. Sure.
Yeah.
What are you stressed about?
Oh, I just I'm hoping that we're still married after this conversation.
Oh, okay. Yeah, I can see.
I don't know what you're going to tell
where
me.
you would think that.
Okay.
Well, just before I explain to you what I know, can you tell me just what is your understanding of how funny you are?
I feel like I'm reasonably funny.
Reasonably. So on a funny scale of 1 to 10, where do you think you would be?
I don't know, a 7, 7 and a
Does
half.
that change day by day, or is
I feel like
steady?
I have a lot of people that think I'm quite funny on social media, and so I feel like I'm probably in the top 10% of funny people.
Okay. Well, I'm not going to sugarcoat it for you. I'm just going to come right out and tell you I am funnier than you.
What?
Yes, I'm funnier than you are. And I don't find you that funny anymore. I'm just being honest. I know this is hard to hear.
What are the chances that you're not funnier than me?
Oh, slim to none. Mm-hmm.
Okay.
Yeah, it's a pretty conclusive finding.
Well, not sure what to say about this.
You can just take a minute and let that sink in. Take all the time you need.
That you're funnier than me.
Yeah.
Is there anything I can do?
You could really try, getting better jokes. I feel like they're getting kind of stale.
Okay.
At this point. I mean, I've known you very well for 16 years now.
Yeah.
I kind of have heard them all. And even when it's new, it's like just old recycled again. So harsh,
but I appreciate you being so upfront with me about this.
You're welcome.
And I hope most people have stopped listening to this podcast by this point.
Well, I don't know. I think they might be agreeing with me.
Okay. That was well done. That was good.
Okay.
How'd she do, Don?
You did, I think you did
pretty good.
Really, really nicely. I think a couple of things, you held his eyes. I saw that. He looked away. You looked away. So I think that was really great. You also did something that I didn't even tell you to do. Is sort of, you let him lead you to the initial conversation. You actually picked up on, how he was feeling, level of stress, and then you got into it. Mm-hmm. And then I think the open and direct approach really did help with the way you delivered that. So kudos.
I feel like I'm already on the path to acceptance here.
Well, you've had plenty of time to realize this particular news.
Okay, my turn.
Okay.
All right.
Okay.
Kristin?
Yes.
How are you?
I'm doing very well today.
Yeah?
I'm feeling pretty good today. There's good days and bad days, but today's a good day.
Yeah, it's beautiful out.
It's sunny. Mm-hmm.
How do you feel about my career choice?
Well,
as an ophthalmologist,
I feel pretty good about that.
Yeah.
Yeah. Mm-hmm.
Well, I'm going to just come out and say this. Mm-hmm. I don't want to be an ophthalmologist anymore.
Mm-hmm.
And I would like to go back to residency
mm-hmm.
in neurosurgery.
Mm-hmm. Mm-hmm.
I feel like the eyeball it's so small.
Okay.
Although it is kind of the leader of the brain, I feel like I could really expand to include much more of the central nervous system. Mm-hmm. And I really think neurosurgery is the place for me in medicine.
So you see the eye as the gateway drug to the brain.
I can't deny it anymore. Okay. It's been something I've been thinking about for a while, and it's going to involve a significant sacrifice for our family. Because,
how long is a neurosurgery residency?
I'm not sure, roughly 15 years.
And how much do you earn in income in that
during that time?
Yes.
It's less than what I make now.
Sure.
A lot.
Uh-huh.
We'll have to sell the house.
Okay. Uh-huh.
Is this
Where
so?
will we live instead?
I don't know. A nice, just we got to downsize just a little bit. We'll have to sell the dog too.
Oh, okay, that's fine.
We can keep the children though.
Okay, good. I'm fond of. Do we have to move in with my parents?
Yes.
Ugh.
I'm sorry. Is this okay with you?
Well,
there's a 50% chance I will not like it and go back to ophthalmology.
Okay.
But
well,
in my opinion, it's worth the 15 years of residency training.
I hear your bad news. I receive that.
Yeah.
In turn, I feel like I need to say something as well. So how are you today?
I'm fine.
Okay. You feeling all right?
I'm good.
Okay.
Like a weight's been lifted off my chest.
Oh, that's wonderful. Okay, good. Well, I just wanted to let you know. I don't want to draw this out any further, but I will be leaving you.
Oh, okay.
And I'm taking the children.
We're going to stop this exercise at this point. I think, I don't know, Don, I think Kristin probably did better than me. I don't feel like I was prepared. I got nervous. I got anxious.
And you know what happens when we get anxious? We ramble, we talk. So she barely had a question when you were already answering it. So, that sort of pregnant pause we talk about, that's what happens, I think.
Yeah.
Yeah, but it's hard to, because, when you become nervous or when you're uncomfortable, you just want to get out. And the only way you're getting out of that room is if you say what you need to say. Right? So I think it was a really interesting thing to see, because you knew she wasn't going to take it well, and she wasn't taking it well.
No, I knew she would. Yes.
Right. So it was an interesting thing to see.
That was great. Yeah, I think we learned some things for sure.
I've learned that you're scared of me,
and that I am, and there are no circumstances to change my career choice in medicine.
Well, certainly not to a neurosurgery residency. I think is pretty good.
That's not into anything that's going to take you 15 years to train. Seriously, I'd be like,
yes,
seriously.
Like not okay. That was fun. I enjoyed that. Well, Don, thank you so much for joining us. This has been a pleasure. Before we wrap up here, tell us what you're up to. What's new for you? Where can people find you? All that stuff. We want to know.
Well, I think because we're not sure which direction Twitter is going to go the next several years.
Right. Yes.
So my go-to is on TikTok. So, I think I would love for people to find me there. And then as a sort of a side gig, I've started my own YouTube channel where I'm sort of posting videos about that too. So find me on social media at Dr. Don S Dizon. Yeah.
And for people who don't know, what are you talking about on your TikTok and on your YouTube?
I'm talking about the humanization of medicine.
Very cool.
Good topic.
Stories from Cancerland, and also the lessons that people who've been through cancer have taught me to get me through the day.
That is
awesome.
Yeah.
It's a great thing. We need more people like you.
Great interest to people. Yeah.
Keep up the wonderful work. And again, we really appreciate you being here with us.
Thank you. And this was so great to be here. Good luck and continued success to you both.
Thank you.
Thank you. You too.
All right. We will be right back to read your medical story. So stick around. And we're back. So let's take a look at some of our favorite medical stories that were sent in by all of you, by the listeners. So we got a couple good ones today. So we have a story from Rose B. She says that one of the earlier pad changes I assisted with as a new graduate gen med nurse.
Okay, wait. What is a pad change for those of us not in medicine?
Yeah. So a pad it goes underneath the patient now, as an ophthalmologist, it's been a while since I've seen one of these, but
because I have some ideas.
I remember, I'm pretty sure it's what goes underneath the patient on the top of the bed. So they're laying on it
like a puppy pad.
Yeah, kind of. And then
when you're potty training a dog, but
Right, but
for a human in a bed.
Right. So basically, all the nurses will kind of roll the patient, remove the pad, change it to a new pad.
Okay.
So that's kind of what a pad is.
Okay, got it.
So this nurse was on the general medicine floor. It sounds like she was doing an earlier pad change, I guess, in her career, an earlier pad change, and was helping a patient. They rolled him onto his back, undid his pad, and got ready to clean him up. All nice and chatty, friendly, no big deal. Like just a thing that happens in nursing care.
They rolled him onto his back?
Yeah, just so they could change the pad. Yeah. And then
Isn't the pad under his back?
what? I'm not sure about
I'm
the
very concerned
physical
about these
logistics.
pads.
You are way too detail oriented here.
Go ahead.
So they rolled him onto his back, undid the pad, got ready to clean everything up, and we couldn't find his penis.
Oh, dear.
So I remember us looking at each other like, what? We hadn't received any pertinent handover about this. I had only seen about 3 penises out of work myself, and sure, I'd seen heaps, but not paid attention as a student. It just wasn't there. He had testicles. It took us about 2 minutes of panicked glances and smiles and just, it's all good, my man, before we realized we had managed to roll him and tucked his penis between his testicles and his left leg. And then the story ends with he had a very normal-sized penis.
Oh, okay.
So it's
Inquiring minds.
Yes. That it's, you know what? When you're like at the beginning of your career, and really any healthcare professional, like you just never know just the strange experiences and the things that you have never seen and learn from. Like I'm sure Rose learned from that experience of
maybe a different
where to find the penis.
To not tuck and roll, just
right.
roll.
Just, I guess, yeah. I don't presume to know really much of anything about nursing care.
Oh, I thought you were going to say about penises.
I know a little bit about those as an owner of one. So thank you, Rose B, for that story. All right, we're going to move on to our second fan story. This is from Rusa P. When I was a teenager, I used to get really bad seasonal flu, influenza every year, and every time it took months or longer for me to get better, partially because I refused to skip school and my hobbies for more than a couple days. One time, I coughed so much that I ended up hurting my ribs, and it became difficult for me to even breathe, so I finally agreed to have an appointment with a doctor. The doctor listened to my lungs and prescribed me with an asthma inhaler for 1 month, and some other meds as well, so that I could recover. Then, just before I left, he remarked, "There's something weird about your lungs." I said, okay, and expected him to elaborate, perhaps tell me to go see a specialist or something. He didn't. He simply nodded and told me to have a good day. To this day, I don't know what he meant by something weird going on with your lungs, but I haven't died yet, so I guess it wasn't anything serious.
It sounds like that was just his medical diagnosis. Something weird. Lungs.
I'm not sure that's an accepted ICD-9 code.
Yeah, how are you going to bill for that?
Although you can find a code like sucked into a jet engine, so I'm sure there's something there you could code for. But let that be a lesson to everybody. Ask questions.
Yeah.
Feel free to clarify anything your doctor says. If they say there's something weird with a vital organ in your body,
you might want to ask about it.
To ask more probing questions.
Yeah, and also for the clinicians among you, maybe just stay away from, quote, something weird. Just generally not great.
So, there's something weird with your brain. All right. See you later.
You know what? How are you doing today? Are you doing okay?
I'm doing fine.
I just wanted to let you know I have been taking a look, and there is something weird with your face.
You've been taking a look? You've been looking at me? All right. I regret ever having someone teach you how to deliver bad news. Okay. So you can send us your stories at knockknockhi@human human-content.com. We want to hear it. So thank you so much for those 2 stories from Rose B and Ruza P. All right. I think that went great. Yeah. I think I loved having Dawn on. Again, oncologists are special to us.
Yes.
With the experiences we've had with cancer. And so it was enlightening and also a little disappointing that he taught you so well how to deliver bad news, because I'm sure I'm going to be getting a lot of bad news over the next few weeks.
Oh, you can count on it after what you've put me through. Sure.
And I do think you won.
Oh,
I think
easily.
You were more comfortable delivering bad news to me than I was to you. So, yeah, but it was a great episode. There are lots of ways for you all to reach us. All right. You can email us, knockknockhi@human-content.com. You can visit us. We're on all the social media channels, pretty much, TikTok, YouTube. It's where else? Twitter. How could I forget Twitter for now? And you can also hang out with us in our Human Content Podcast family on Instagram and TikTok at Human Content Pods. Thank you to all the great listeners, all of you leaving wonderful feedback and awesome reviews. We really appreciate it. If you subscribe and comment on your favorite podcasting app or on YouTube, we might give you a shout out.
Right.
Yeah. We're on YouTube as well. Full video episodes up every week on my YouTube channel.
You're more of a visual learner.
That's right. Yeah. At D Glaucomflecken. Why did I not just do Dr. Glaucomflecken?
I don't know.
Does it bother you?
Yes.
It probably does. Yeah. D Glaucomflecken. I chose that. I did it years ago. I had no idea.
Why even put the D?
And we're also on Patreon. We have tons of cool perks like bonus episodes where we react to medical shows and movies. Come hang out with the Knock Knock Hi member community. We're active in it. We'll be there.
We'll be
talking. We'll be responding and things. Also, you get early ad-free episode access, interactive Q&A live streams. We are active. We are there. We are interacting. Come hang out with us.
Party.
Also, early ad-free episode access.
That's right.
As a member of our community, interactive Q&A live stream events, a lot more. We'll see. We'll see what we end up doing.
Yeah, throw some ideas at us. We might take them.
So patreon.com/Glaucomflecken, or go to our website at glaucomflecken.com. Thank you all for listening. We are your hosts, Will and Kristin Flannery, also known as
the Glaucomfleckens.
Special thanks to our guest today, Dr. Don Dizon. Wonderful guy. Really enjoyed that. Our executive producers are Will Flannery, Kristin Flannery, Aaron Corney, Rob Goldman, and Shanti Brook. Our editor and engineer is Jason Portizo. Our music is by Omer Benzvi. To learn about our Knock Knock Hi program disclaimer and ethics policy, submission verification on licensing terms, and HIPAA release terms, you can go to our website, glaucomflecken.com, or reach out to us at knockknockhi@human-content.com with any questions, concerns, or if you have a fun medical joke. I like jokes. Apparently, I'm not as funny as I thought I was. And so Kristin has informed me. So
yeah, you tell jokes.
So help me out. I need new jokes, I guess. So send them to us. Knock Knock Hi is a Human Content production.
Knock knock. Goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Hope you subscribe, leave a comment below. Let us know what you think.